I'm Peggy Peck, MedPage Today, at the American Society of Clinical Oncology meeting in Chicago. The addition of cetuximab to cisplatin-based therapy may provide a significant survival advantage for patients with non-small cell lung cancer. I discussed the findings of the FLEX trial with Dr. David Johnson, a well-known lung cancer researcher and one of the investigators with the Avastin trial in non-small cell lung cancer. I'm here with Dr. David Johnson at ASCO. We've heard some interesting data reported today from the FLEX trial, and I'm wondering if you can just put this into perspective for clinicians.
Sure, I'd be happy to. The FLEX trial was basically a phase 3 study that looked at patients with advanced disease that were given a standard chemotherapy regimen with or without cetuximab. And the top-line data basically show a survival advantage for the patients who received the cetuximab.
So, in your opinion, then, the survival advantage, by the way, was small, but it was significant. Is that correct?
That's correct. The median survival difference was approximately 5 weeks. The 1-year survival difference was approximately 5% in favor of the cetuximab group.
So put this into perspective, like what does that mean if we go back and look at the what effect in terms of survival chemotherapy had, et cetera? So we could put in.
Sure. Well, obviously in advanced disease, untreated, it's uniformly fatal. Only about 10% of patients would survive for 1 year. Historically, when we started using chemotherapy, particularly cisplatin-based chemotherapy, 1-year survival increased to around 20% or so. When we went to the more modern chemotherapy agents in combination with a platinum compound, 1-year survival increased to around 30 to 35%. More recently, in selected populations with advanced disease, such as were included in the ECOG trial with bevacizumab, the 1-year survival actually rose to 50%. But that was a selected group of patients with adenocarcinoma good performance status.
This is a much broader, in FLEX, much broader population of patients, is that correct?
Yeah, I think that's the real significance of this trial. This trial was indeed a much broader group of patients with different histologies, squamous and adenocarcinomas, including PS2 patients. And in spite of that, a survival advantage that was highly statistically significant was observed.
So when you go back to your practice, to your lung cancer patients, will you be using this? What effect will this have on your treatment strategy?
Yeah, absolutely. I think this is a drug that's very familiar to oncologists, and I think it's very appropriate to consider discussing these data with one's patients.
Just one other issue. It's been some speculation, maybe perhaps a little more than speculation, that this drug may not be effective in patients with KRAS mutation. The drug itself, cetuximab, is very expensive. So, but the test for KRAS mutation, not so expensive. Can you just put this into perspective in terms of would you, before going ahead with cetuximab, would you in your own practice do KRAS testing?
I think it's premature to discuss that with this particular study, but certainly in other diseases such as colon cancer, KRAS has been shown to be a negative predictor for response to cetuximab, and with other drugs that target EGF, such as the TKIs, the tyrosine kinase inhibitors. The same has been shown to be true, that if you have a KRAS mutation, you're not likely to respond.
So to sum up, findings that can go from the podium to the patient. Adding cetuximab to cisplatin-based therapy provides a significant survival benefit for patients with non-small cell lung cancer. I'm Peggy Peck, MedPage Today.